Good morning, everyone. First of all, I would like to thank Dr. Raju Garg and the organizing committee for giving me this opportunity. And also, I would like to thank the senior cardiologists and delegates on the dais. So my topic is on hypertrophic cardiomyopathy. I'll be focusing mainly on myosin inhibitors, which are the novel agents which been tried in hypertrophic cardiomyopathy as a disease-modifying agents. So coming to the hypertrophic cardiomyopathy, it is the most common monogenic cardiac disorder and which is highly prevalent. 1 in every 250 to 500 adults. And the main characteristic feature is the thickening of the heart muscle, mainly the septum and the LV. And these patients have an increased risk of arrhythmias. And the sudden cardiac death is the most common cause of death in such patients, especially young patients and in athletes who are involved in competitive sports. If you look back to the history of HCM, such pathology has been reported more than 2 centuries ago, but in 1958, when Thierry, a London pathologist, described the hearts of 8 patients with probable HCM, among the 8, 7 had a sudden cardiac death. Following the subsequent years, there was a lot of study done on the invasive hemodynamics, and in April 1964, there was a 2-day symposium held in London, where the eminent cardiologists, cardiovascular surgeons, and pathologists were involved in the meeting to discuss a relatively new entity known as HCM. In HCM, the obstruction is dynamic and it varies inversely with the LV volume. So initially, all these people thought it was a subaortic membrane, but to their surprise, when they took to the surgery, they could not find any membrane. So during the invasive hemodynamic studies, they found the obstruction is dynamic and there is no presence of any such membrane. And the characteristic feature in HCM is the hypertrophied basal septum and the systolic anterior motion of the anterior mitral leaflet. If you look at the variants of HCM based on hemodynamic classification, it follows the rule of 1/3. So first is the non-obstructive HCM, where the resting LV gradient is less than 30 millimeter of mercury. Here we can see the ventricular septum is involvement of only at the apex, known as apical HCM, or at the septum with a reverse curve or the sigmoid shape without any obstruction. Next 1/3 comes the obstructive HCM, where the resting gradient is more than 30 millimeter of mercury. Here we can see thickening of the basal septum, creating obstruction at the LVOT, or it could be at the mid-ventricular level, mid-ventricular obstruction. And this further progresses into LV apical aneurysm. And the third variety is the latent obstruction, where the resting gradient is less than 30, but with provocation, the gradient goes beyond 30 millimeter of mercury. So we can see with provocation, the gradient becomes obvious. So before labeling someone as a non-obstructive HCM, we need to do optimal provocative testing to label them as non-obstructive HCM. Because the treatment varies between the two groups, between the obstructive and non-obstructive, we have many agents available to treat obstructive HCM, but very few are available for treating the non-obstructive HCM. So genetics play a major role in HCM. It is a single gene disorder, and most commonly the inheritance is autosomal dominant. So if we can see 60 to 70% of the HCM cases are familial, while the remainder 30% may be sporadic. Among all the genes, so 2 major genes are the myosin binding protein C3 and the beta myosin heavy chain 7. So both of these genes contribute to 85 to 90% of the frequency in HCM. Rest all genes involving the troponin I, troponin T, tropomyosin, and the myosin light chains actin contribute to less than 10%. Total 30 to 50 genes are being studied when we send the sub-patient for the genetic testing in HCM. If you look at the presentation of such patients, many can be asymptomatic or they present with symptoms such as fatigue, exertional dyspnea, angina. Angina can be multifactorial in such patients. One is because of the hypercontractile LV or the thickened LV, and the intramural coronary arteries are thickened with a decreased lumen area, contributing to angina in such patients, arrhythmias, syncope, eventually heart failure, and sudden cardiac death. And multimodality imaging plays a crucial role in diagnosing such patients. ECG and echocardiography plays a role in screening. And recently we can see AI-based algorithms helps to better screen such patients to minimizing the errors. And the cardiac MRI offers a greater spatial resolution, useful in identifying HCM mimics such as Anderson disease, Fabry's, or other glycogen storage disorders. And the extent of LGE can be seen on cardiac MRI. And it also helps to accurately measure the IVS thickness because of the greater spatial resolution. And also we can look at the mitral valve pathology, whether it is primary or secondary. And the risk of sudden cardiac death can also be known based on the cardiac MRI. So provocative testing for LV outflow tract obstruction, like I said before, it is important to reveal the latent obstruction. So dynamic obstruction increases, have an inverse relation with the LV volumes. So all our patients, when undergoing the echo, when they have a basal normal gradient, they should undergo a provocation test with a Valsalva. And the quality of Valsalva which our patients do is suboptimal. So they should have a manometry, and they should blow into this manometer, creating a pressure of 40 millimeter of mercury, and it should sustain for more than 15 seconds to have a better Valsalva phenomenon. Other provocative testing like standing, exercise, stress echo, or use of inotropic agents or inhalation lamella nitrate can also be tried. So in the bottom image on the echo, we can see the color Doppler pattern, where the basal gradient is only 19, but with provocation, the gradient has increased to 63 millimeter of mercury. And typically in HCM, we can see this dagger-shaped appearance of the flow pattern. And coming to the histology, comparing with the normal heart histology, in hypertrophic cardiomyopathy, we can see the myocytes are enlarged and are in disarray, with also a lot of interstitial myocardial fibrosis. All the white matter what we see in this histology is the fibrosis. So the most common complications we see in HCM is the sudden cardiac death, and the annual incidence is around 1 to 2%. The cause is ventricular fibrillation. Martini Maran et al. From Boston has reported more than 2,000 patients with HCM. Among them, 1/4, around 527 patients, had more than one risk marker for sudden cardiac death. And all of these patients underwent a ICD implantation for primary prevention. Among these patients, almost 16% had received a shock from the device to terminate a VF for VT. So with the invention of ICDC from 1980s, the incidence of sudden cardiac death has came down to less than 0.5% per year. So the recommendation for ICD in HCM. So HCM risk score, we have two recommendations. One is from the ESC recommendations from 2023, and the other one from the 2024 AHA ACC recommendations. So both of these two use different parameters. The ESC is more specific, and the AHA recommendations are more sensitive. So the presence of more than one of these seven, we qualify the patient for a ICD for primary prevention. And the second most complication is the heart failure. Because with the invention of ICDs in 1980, the risk of sudden cardiac death has came down. So eventually all these patients end up in heart failure. So it became the greatest concern nowadays. So LVEF less than 50% in such patients represent serious LV dysfunction. Because in HCM, these patients have a supranormal EF of around 75 to 80%. When the EF drops below 50%, we should think that it is a severe LV dysfunction. So heart failure occurs due to marked hypercontractility or with the extensive cardiac fibrosis. So data from the HCM registry showed that pathogenic sarcomere variants are seen in patients with LV dysfunction. And the higher incidence, when the patient develops heart failure, they have higher incidences of death from any cause, higher risk chance of stroke and atrial fibrillation. So in such patients, septal reduction therapy should be tried. And when the heart failure develops, we can see some improvement in the LV function also after septal reduction therapies. And in appropriate patients with a left bundle and QRS more than 150, even CRT also can be considered when the patients develop heart failure. And all patients we should initiate on GDMT. And when the patients become to stage D heart failure, when the medicines are not working, we need to consider for advanced therapies, such as heart transplant or LVAD as a treatment option. And third is the atrial fibrillation. Almost 1/4 of the patients with symptomatic HCM will have atrial fibrillation. AF is associated with the poor patient outcomes and higher risk of thromboembolic events. So LA enlargement and fibrosis plays a major role in the atrial fibrillation. And in HCM patients with AF, Shadworth score are not helpful. So all the patients should be on prompt anticoagulation. And the pharmacological rhythm conversion should be tried initially with amiodarone. When it is not working, catheter ablations also should be considered. During, if the patient is going for a septal myectomy, surgical ablation such as Mace procedure or ligation of the appendage also should be considered in the same setting. So this is the algorithm from the recent review of symptomatic HCM. So all of these patients should be on the first line medications such as beta blockers or the calcium channel blockers as per patient tolerance. So if the symptoms still persist, we should add a disopyramide. Nowadays, we have a newer agent in the pipeline, which is the cardiac myosin inhibitors. So they should be tried before considering for a septal reduction therapy such as surgical myomectomy or the alcohol septal ablation. Because these therapies, the septal reduction therapies requires expertise and are available only in designated centers. So next few slides, I'll be talking more on the cardiac myosin inhibitors in HCM. So what happens in HCM is, if you look at the normal sarcomere, so having an optimal number of myosin-acting cross bridges, whereas in HCM, there will be increased number of cross bridges due to the gain of function mutation. So leading to the increase in the proportion of cross bridges in the active state, which leads to the adverse structural, energetic, and clinical consequences. So cardiac myosin inhibitors plays a crucial role in decreasing the number of cross bridges, maintaining it to the optimal number, thereby giving benefit to the patient. And the chemomechanical ATPase cycle of cardiac myosin inhibitor, if we can see, mavacamten and aficamten are the two currently available myosin inhibitors. So this mavacamten helps to maintain the myosin in a super relaxed state. So both of these drugs slows the release of inorganic phosphate, thereby preventing the power stroke and leading to the sarcomere going to rigor state is prevented with the use of these myosin inhibitors. So we'll be talking on the Explorer HCM trial. So cardiac myosin inhibitors, we all know that in HCM there is excess of actin myosin cross bridges leading to increased myocardial contractility and energy requirements. So mavacamten is an allosteric inhibitor of cardiac myosin ATPase that blocks the excessive bridging and shifting the myosin to an energy-sparing, super relaxed state. In Explorer HCM, it was a multi-center, double-blind, placebo-controlled trial which enrolled 251 patients with obstructive HCM, and the patients are symptomatic of NYHA class 2 to 3. Most of them are already receiving a beta blocker. So 70% of these patients were on beta blocker. So by the end of 30 weeks, the patients on mavacamten, they had a maximum oxygen uptake on CPET, and improvement in the NYHA function class showed mavacamten to be superior to the placebo. So this was the primary endpoint in this trial. So there are some secondary endpoints such as reduction in the LVOT gradient. So LVOT gradient reduction was seen by 40% when compared with the placebo. And also mavacamten associated with a greater reduction in the LV wall thickness, mass, LV mass, and improvement in the NT-proBNP levels and high sensitive troponin levels compared to the placebo. And also the clinical performance scores such as Kansas City cardiomyopathy questionnaire score also has improved. So after the trial and washout period, all of whom who received mavacamten, the efficacy remained for more than 3 years, even after stopping the drug. So hence, mavacamten was approved by FDA in 2022 and is available in the market in many other countries with a REMS criteria, which is a risk evaluation and mitigation strategy. When they're launching a new drug, to minimize the risk, they give this REMS criteria when approval by the FDA. So one more trial is the Valor HCM trial. So it was done by Dr. Desai. Yesterday we have a great talk by him in the afternoon session on HCM and mavacamten. So he was a principal investigator in the Valor HCM trial, which enrolled 112 patients with obstructive HCM who was referred for a septal reduction therapy, because all of them are symptomatic, in spite being on the first and second line drugs. So these patients received mavacamten or the placebo for 16 weeks. So surprisingly, by the end of 16 weeks, 77% of the patients in the placebo group remained eligible for the septal reduction therapies. However, only 18% in the mavacamten group. That means 82% who received mavacamten doesn't qualify for the septal reduction therapy because the gradients has came down in such patients. So evidence of favorable cardiac remodeling is seen, and the results of the real world data are also been positive and encouraging with the mavacamten. So second line, second drug in the pipeline regarding the cardiac myosin inhibitor is aficamten, which also binds to the myosin, but at a different site compared to mavacamten. So we have a Sequoia HCM is a phase 3 placebo-controlled trial involving 282 symptomatic patients with obstructive HCM. And the primary endpoint was change in the VO2 max during cardiopulmonary exercise testing by the end of 24 weeks. And there was significant improvement in the VO2 max, the oxygen consumption, compared to the placebo. And the secondary endpoints also, there was improvement, which include the LV wall thickness reduction, reduction in the ventricular mass, reduction in the LA volumes, and improvement in the health status were similar to the mavacamten. So if you look at the change in the exercise capacity from baseline to week 24, so we can see the placebo arm remained same, where the peak VO2 was around 18.5, whereas in the aficamten group, there was a remarkable increase in the peak oxygen uptake from 18.5 to almost close to 20 mils per kg per minute by the end of 24 weeks. The change in the peak oxygen uptake also, we can see there was almost increment of 1.7 mils per kg per minute in the patients received aficamten, which was statistically significant. The key secondary endpoints also we can see there is a change in the peak resting LVOT gradient and the change in the peak LVOT gradient after Valsalva maneuver. So we can see in the aficamten group, the dropping in the gradient we can see as early as from 2 weeks and has been persistent till the dose titration of 8 weeks. And the gradient has been maintained till 24 weeks. And by the end of the study, during the washout period, we can see again the gradient going back to the baseline. So both in the resting and the peak LVOT gradient during Valsalva, we can see the similar results when compared with the placebo. And the other key secondary endpoints, we can see there is improvement in the NYHA function class. So from week 2, we can see almost 15% of the patients going up to 60% of the patients. By the end of 24 weeks, we can see the improvement in the NYHA function class. Similarly, the change in the KCC questionnaire also, we can see there is improvement in the aficamten group by the end of 24 weeks. So significant difference compared to the placebo. And during the washout period, again, all of the patients came back to their baseline function class. So comparison of phase 3 trials between the two molecules, mavacamten and the aficamten. So duration of therapy in the mavacamten is 30 weeks, and in aficamten it was 24 weeks. So both of the patient criteria were similar in both the trials. The median age was 59 years, and the females were 41% in both the trials. And all the patients had a peak LVOT grade more than 50, and majority of them are symptomatic at NYHA function class 2, more than 70%, and the rest are NYHA function class 3. And the majority of the patients received beta blocker in the mavacamten group, which was 75%, whereas in the aficamten group, only 61% received beta blockers, and around 11% received the disopyramide. The primary endpoint we can see in the mavacamten group, increase in the peak oxygen uptake of more than 1.5 mL per kg per minute. And in the aficamten group, also we can see the improvement in the peak oxygen uptake was significant compared to the placebo, with significant p-values. So major drawback we have seen in few patients is almost 4% of the patients we can see a drop in the ejection fraction because of the negative inotropic effect. And it was 4.8% with the aficamten group. So number of patients with the ejection fraction less than 50% was 7 in the mavacamten group. So we need to stop the drug in such patients. In the aficamten group, it was a 5 participants. There was a drop in the EF to less than 50%. So when comparing the two newer drugs, mavacamten versus aficamten, mavacamten has a longer half-life of 7 to 10 days, whereas aficamten have a shorter half-life of 3 to 4 days. So that when we stop the drug because of any drop in the EF, so the washout period is much quicker, and the regain of the EF can be seen within a week to 2 weeks. So mavacamten has an unpredictable and variable dose response, whereas aficamten has a more predictable and stepwise dose response because of the shallow drug response with the aficamten. So mavacamten has a slower onset of action starting from 4 to 8 weeks, whereas aficamten, because of the shorter half-life, the faster onset and the improvement we can see as early as from 2 weeks. So mavacamten has a higher incidence of drop in the LVEF to less than 50%, whereas aficamten has a lower incidence of EF drop. And mavacamten has a lot of interactions because it is metabolized by the CYP2C19 and CYP3A4. So a lot of interactions with the antifungals and other antiarrhythmic drugs, whereas aficamten has less dependency on the cytochrome for metabolism. So mavacamten has a higher and more frequent dose holds because every 2 to 4 weeks we need to monitor the EF, and we need to hold the dose because if we notice any drop in the EF compared to the previous dose. Whereas aficamten, the dose titration was much smoother and have a fewer dose holds with aficamten. So the recommendation, the current practice guidelines has recommended the administration of cardiac myosin inhibitors in adult patients with obstructive HCM who remain symptomatic despite receiving the first line of therapy. This new class of drugs altering the treatment options with obstructive HCM. So when cardiac myosin inhibitors become generally available and also affordable, the oral administration of these medications may reduce the need for the septal reduction therapies. So aficamten compared to mavacamten showed a better pharmacodynamic profile with a fewer adverse effects. So one more trial is the MAPLE HCM trial done in Madrid, Spain by Dr. Pablo Garcia. So in this trial, they compared aficamten monotherapy with the beta blocker monotherapy. So unlike previous Explorer and the aficamten trials, where they added the myosin inhibitor addition to the beta blocker. So this trial was done exclusively to know the individual benefit, aficamten monotherapy versus beta blocker monotherapy. It is an international double-blind, double-dummy trial in adults with symptomatic obstructive HCM. They randomized 1:1 with one group receiving aficamten starting at 5 mg, and every 2 weeks they upgrade to 10, 15, 20, plus placebo, or the metoprolol starting at 50 mg and updated to 200 milligrams by the end of 6 weeks with the placebo. The primary endpoint was change in the peak oxygen uptake at the end of 24 weeks done on cardiopulmonary exercise testing. So aficamten monotherapy was superior to metoprolol monotherapy in improving the peak oxygen uptake and also the hemodynamics and decreasing the patient symptoms. So we can see the primary endpoint in the MAPLE HCM trial. So in the aficamten group, we can see the peak oxygen uptake has increased from 19.5 to almost 20.6 by the end of 24 weeks. And the change in the peak oxygen uptake, there was a significant difference, almost 1.1 increase in the peak oxygen uptake. Whereas in the metoprolol group, we can see there is a drop in spite of, without liking the rise, there is a drop in the peak oxygen uptake from more than 20 to almost 1.2 mils per kg per minute drop in the peak oxygen uptake by the end of 24 weeks. So what are the improvements we see by the cardiac myosin inhibition therapy? It is a disease-modifying agent. So we can see improvement in the LV voting gradients, improvement in the LV wall thickness, reduction of LV mass, and reduction of hypercontractile LV. And the cardiac energetic requirements are becoming better with a decrease in the LV volumes and the filling pressures. And we can see a decrease in the E by E prime ratios with improvement in the function class. In the Cirrus HCM trial, so the third novel cardiac myosin inhibitor is the EDG 7500, which is currently in the phase 2 study. The drug was developed by Edgewise Therapeutics, so testing EDG 7500, a cardiac sarcomere modulator. So surprisingly, this is being tried in both obstructive and non-obstructive forms of HCM. So the study was done in 4 parts. First part A, they included a single dose for a shorter duration. Part B, they included multiple dose combinations for 28 days. And the part 3, they studied in the non-obstructive HCM also for 28 days. And the part D, they included for a longer duration of study for beyond 12 weeks plus extension. And the key metrics outcomes they measured were the LVOT gradient, LVEF, NT-proBNP, and the Kansas City questionnaire. So surprisingly, they showed a robust drop in the gradient within a short time. So safety-wise, it was very safe. No concerns of drop in the LVEF compared to the prior drugs such as mavacamten or aficamten. Efficacious, we can see robust drop in the gradients within 2 weeks without concern of drop in the EF. So monitoring, no excessive monitoring is required unless the prior drugs. And diastolic effect also improvement can be seen. So has been tried in non-obstructive HCM forms. Dosing also, it's simple, easy, fixed once daily dosing unless titration with the prior drugs. And the newest invention is the gene therapy, because these drugs which we tried did not show any much benefit in non-obstructive HCMs. So gene therapy has been tried because all these are the monogenetic disorders in HCM. So 3 approaches. One is the gene editing, gene silencing, or replacement of the defective gene is being tried, but quite early and naive. So all of them are still at the phase 1 trials in symptomatic patients with non-obstructive HCM. So take-home message from my talk. So HCM is quite prevalent in the community. So before labeling as a non-obstructive HCM, provocation should be done optimally before labeling as a non-obstructive HCM, because the treatment options are varies between both of the forms. So initially we should try the first-line agents such as beta blockers or the calcium channel blockers, because they are widely available, cost-effective, and acceptable by the patients. septal reduction therapies are limited only to few centers of excellence. So the new drugs in the pipeline are the novel cardiac myosin inhibitors, which are showing promising results, limited options for a non-obstructive HCM, and the future appears bright for HCM with a precision medicine. Thank you.